Hey, everybody, welcome back to a podcast to answer your questions on addiction, recovery, and mental health by Waismann Method Opioid Treatment Specialists and Rapid Detox Center. I'm your co-host, Dwight Hurst, and I'm joined as always by Claire Waismann and David Livingston. Well, we're trending today, as in we're talking about some real current events that are happening in the field and the world of addiction treatment. So we're starting out with, I'm going to read the headline from an NPR article by Brian Mann, where he's summarizing and talking about this breaking news. It's called, As Opioid Deaths Surge, Biden Team Moves to Make Buprenorphine Treatment Mainstream. Buprenorphine, did I say that right? Buprenorphine. So to make buprenorphine treatment mainstream. And it's talking about an announcement that's just been made within the last few days, I think, if not the last week. Talking about how federal guidelines are changing with treatments and some real big news. And we're going to get into that, of what that means and how you feel about it. So it might be good for those who don't know what buprenorphine is. How could we nutshell that to let people know a little bit what that is and what this change represents?
Okay, so buprenorphine is a drug that contains an agonist and an antagonist. So it's an opioid medication that is used to control opioid use. So in other words, it's not a detoxification, but patients that are using heroin, patients that are using high doses of prescription pain opioids, they use buprenorphine drugs in order to kind of regulate what they're taking and, more importantly, limiting the risk of overdosing. So that is, the goal of the buprenorphine, is maintaining the patient without withdrawing or craving for their chosen opioids that is out of control.
And I'm trying to remember, is that in use at Waismann Method? Is that used? Is it one of those that's
No,
used
we do
occasionally,
not.
or you guys don't use it at all, right?
We do not use any maintenance opioids. We actually detox patients from them. So buprenorphine-based drugs like Suboxone is on the first three drugs we detox most of our patients from, because they are long-acting drugs and the withdrawal can be quite extensive.
So you'll sometimes work with people who are on, if I'm not mistaken, naltrexone, which is a whole different thing, right?
No. Naltrexone is a antagonist. It's not an opioid at all. So it is the complete opposite. Agonist is an opioid because it attaches to the receptors.
Right.
Antagonist is the opposite of an opioid. Naltrexone is an antagonist, has no opioids, have no addictive abilities, and it causes zero withdrawal.
So that's important to recognize the difference between those two medical approaches. Yeah. For sure.
Right. So naltrexone is a drug that is used once the patient is off opioids completely. And it is used to eliminate cravings because it blocks the receptor sites. But again, it's not a drug that can be addictive or has any withdrawal symptoms if the patient decides to stop.
And that's really I'm sure, that's going to get into some of the feelings that this brings up. But that's an important difference for people to recognize right up front. So it's not all the same thing when you hear someone say, oh, it's medicine used to treat addiction. Yeah, but they're very, very, very different types of medicines. Gotcha. Yeah.
Well, because addiction, there's so many different, factors that, it becomes addiction. I mean, from the physiological part of it to the emotional part of it. I mean, it's not just one facet.
So let's maybe then talk about what this change represents. One of the things that I see from the article is that they're releasing some guidelines or relaxing some guidelines, that some trainings that were required before practitioners could prescribe buprenorphine.
Correct.
Am I
So
seeing that correctly?
they're lifting guidelines that will allow health workers and not just doctors to prescribe buprenorphine-based drugs. What allows rural areas that do not have the right amount of physicians to be able to prescribe more of this drug, hoping to eliminate the overdose issue. So that's the pro.
Gotcha.
The con is you have a number of health workers without training, because that's something else that they are removing, is the training necessary to prescribe these drugs. What can cause a tremendous amount of issues.
Yes.
So again, we got to put it on the scale, the good and the bad. And then you have, for me, the more important issue. Are we putting another Band-Aid in a sore that continues to grow?
Mm-hmm.
So the issue here is, not the overdoses,
Mm-hmm.
is why are there so many overdoses? Why are people using, so much drugs? Why have the drugs become so much more dangerous than they used to be? So that's what I'm trying to say. I think that's a very one-sided solution to a multifaceted problem.
And that's something that comes up a lot with any kind of nuanced problem. But I think we've discovered this and touched on this on the show before, that any type of a nuance or trying to take a multifaceted approach to solve a big problem is, well, it just doesn't happen as much as we would hope that it would.
Right, because we're hoping for easy miracle solutions that sounds very good. I mean, I think anybody working for a solution of a problem like the opioid crisis, it's a plus. But we have to make sure that people are educated in what the treatment is, what it's supposed to do, its risks and its benefits in any treatment.
I don't know if I've told this or touched on this during the podcast before, but I remember working at a place once where there was a really big morale problem. It was a pretty bad culture that had grown out of it. It was managed healthcare, and a lot of people were burned out. And one of the administrators decided that we were going to start having brown bag lunches once a month, that everybody would gather together and enjoy each other's company. But it was not quite mandatory, but it was expected that you'd be there. You had to use your own lunch break. You had to bring your own food. And you also were expected to, be careful about not getting back to work too late after. So it didn't work. To shorten the story. And it was this one chop to knock down a huge big tree, right? And it sounds like that's one of the major concerns, is it's not addressing all the facets of the problem.
Yeah, I think I go back to the same place every time. I wish administration would put 10% of their pharmaceutical efforts into mental health care. And I think we would be solving a lot more problems, because now we're dealing with the real issue. Is why are we suffering so much? Why are people hurting so much? Is it an opioid crisis, or is it distress, an emotional distress crisis?
Yeah.
Because again, if they don't have the opiates, they will look for the alcohol, or they will look for something else. They're trying to treat those emotions they cannot handle. And if we offer them the mental health care they needed, then we wouldn't be in this situation in the first place.
There are benefits to the buprenorphine, particularly with people who are at high risk of overdosing, who, for one reason or another, are at risk, and you're really trying to do a process of harm reduction. And I think Suboxone those medications can be useful for a certain group of people in terms of harm reduction. And I think one of the things that happens when you're treating people very often is that the goal is to do the harm reduction, and so doing, and because of that, that's the initial impetus. And so the difficulty of getting off it, and the fact that it's such a long-acting opioid and stays on, it's very, very difficult to get off of. Sometimes people can, but very often they can't, because it goes on, the detox process goes on so long. It's rarely talked about up front. And there's no really, the idea that you can titrate down is true. You can titrate way down, but the very end goes on for a long, long time, and it's very hard on people. So I don't think there's a big educational, a big desire to educate, particularly upfront, because the desire is to get people onto the medication and out of harm per se. And I can see the rationale for that. I tend to think that it's better to tell people as much as possible. And some people don't do well. We've seen a lot of people who've been on buprenorphine and not done that well. They haven't felt well on it. Like any medication, some people are fine on it, some people aren't, and they don't respond well to it. So it's complex. I understand the reasoning behind it to some degree. I do think what Claire's saying as well, in terms of, really trying to create a different standard of care where there's really a process of trying to help people in a prolonged way is another approach, because you often see people go on medications and then it becomes kind of on and off this or that. And some people can do well. So it's complex. There isn't an easy answer, but there should be a lot of evaluation up front and a lot of education up front is my belief.
And that's often what's missing, right?
It is exactly, and that is one of my major concerns with the new guidelines, put in place right now, is because they are eliminating a lot of that education for healthcare workers. And they're dealing with a population, that is not just physically impaired, but emotionally as well. So when you remove the education needed in order to treat these people, there's going to be a lot of mishaps. And I don't think people can afford any more mishaps on the treatment of their health.
Well, we've seen quite an uptick in overdose deaths and also in drug use over the pandemic, right?
Right. What it was to be expected. And now when you're talking about opioids per se, tick on overdoses is due to fentanyl. Most people that call us today, regardless of what they were taking before, and David, you probably can attest to that, they're actually taking fentanyl. Fentanyl has been introduced in every possible drugs being sold out there, from Xanax to heroin to prescription pills. They're buying prescriptions, so they could be oxycodone, it could be Norco, it could be whatever, Percocet. Truth is, it is fentanyl. So because fentanyl is introduced to all these drugs, the level of risk of overdose have multiplied. And that's where you're seeing all these overdoses. And they don't expect it to be fentanyl. Actually, a lot of the patients right now, believe it or not, they have a little test kit with them when they buy drugs in the street to make sure, the amount of fentanyl in it.
Oh, really?
Oh, yeah. That's how crazy it has gotten. The issue with the crisis, there's so many facets to it that we have to protect our citizens from the lack of mental health to, fentanyl just flooding every corner of our society.
And one of
being locked up.
Absolutely. One of the things that I know we talked about it, and some people talked about it, but I didn't hear it talked about enough during the pandemic, and people not being able to access. People weren't able to access healthcare sometimes for things that were not a crisis, and they also sometimes weren't able to access drug use as much either. So there was a lot of withdrawals from alcohol use and opiate use, and what we're talking about is a medication that does cause withdrawal. And so I could see some of the same problems potentially if you can't get access to refill a prescription for this, perhaps, if there is another uptick in healthcare needs and mutation of COVID. I mean, not to be doom and gloom, but I could see that being a problem as well.
No, yeah. And there's something else too. One of the biggest complaints when I speak to a patient that did take any buprenorphine drug is they will say, "Oh, I'm allergic to buprenorphine." And I say, "What does that mean?" "Oh, when I took it, I was very, very sick." That means they taken too early, because there has to be, a time lapse between the last time they use an opioid to taking buprenorphine, or it will send them into an instant withdrawal. The issue with that becomes now you're dealing with fentanyl, that is a much stronger drug that can last in their system a lot longer. Now, if trained doctors are having a hard time figuring out when to give and what dosage to give buprenorphine, imagine untrained people. You got to understand, once opiate patients feel desperate, especially feeling withdrawal, what do they tend to do? The only thing they know that makes them feel well. Now, you have a drug like buprenorphine, that is an agonist and antagonist, and you try to use opiates so you feel better from the side effects of buprenorphine. I mean, it's just going to be a nightmare. I think if money should be spent, should be in more training, not less.
I think what happens is people are put on buprenorphine. I'm not even sure I'm saying it correctly exactly.
Buprenorphine.
Yeah, thank you.
It's a good thing we have Claire on the line. She knows how to say it. I always mess it up.
And I'm the only immigrant here.
Exactly right. One of the things I see patients who come through, and in listening to their stories and having worked with, hundreds and hundreds of people coming off of Suboxone, you'll hear different stories like, I didn't know I was getting on a drug that was going to be harder to detox. I was on, I had a back surgery and then I was put on this, told it was a treatment, or it was, without any education or knowing that how hard it would be to get off of. And so there's often which is very different than if somebody is at risk, for overdosing or something like that. And sometimes people will be at risk for that and put on it for a number of years. And then they're like, oh, I got to get off it. I can't get off it. So, we see a lot of people coming through who are just done with it all, and they don't want to be on it. They don't feel good on it. And whether it's, in the beginning or eventually, very often people stop feeling good on buprenorphine. It tends to sort of eventually the body can reject it. And I know that's not necessary. When people are in danger immediately, that's not a concern. And I can appreciate that, because certainly trying to curtail the overdosing makes more sense than anything. But not everybody is a candidate for it. It is not depending on what people are really needing. And so there really needs to be an evaluation, a really sincere evaluation, rather than just pushing everybody to it because everyone's in danger of overdosing. Everybody isn't in danger. Some people are. And you really can, if you really listen to them and And, if you're not pushing them one direction or another, they'll generally tell you what's going on. So that's a concern, because I think actually people can later get into more trouble, like Claire was saying, when you can't get off of it, and then you're not sure what to do. And when people are in that state or going through prolonged withdrawals, they go into a fight or flight reflex at a certain point, and they make bad decisions and often go back on opioids or things like that. I've heard that many, many times. So it's a complex issue. I don't know. I don't think it's being addressed at all in the way we're talking about it, or even talked about in the way we are. So, again, I understand some of the reasons why, like you don't want people dying, and you want to, that's the major focus, but it's more complex by far.
An example of what David is talking about, Dwight. So this week we had this guy calling us. He has, cardiac issues. He has had a number of different surgeries. He is on blood thinners, and he is over 250 pounds. He was taking 4 Percocets a day. His doctor put him on 16 milligrams of Suboxone a day. I can't even tell you what the difference of 4 Percocets and 16 milligrams of Suboxone is the same as if he came here, and I'm going to try to give you an idea, saying that he was drinking 2 beers a day, and I gave him a bottle of vodka to have a day. So a patient that normally we would accept and put him in a hospital in detox while controlling his heart rate, blood pressure, make sure a specialist was there, to make sure there was no stress, and get him off 4 Percocet quite easily.
Yeah.
We had to deny treatment because of the levels of the amount he's in and what a withdrawal for 16 milligrams of Suboxone will be. And his body wouldn't be able to take it. So what they have done of this guy is get a patient that was absolutely treatable to a patient that now has to start titrating, and then his blood pressure go high and his heart rate gets higher. So he's actually in much more health risk than he was before. And nobody wants to touch him.
It's got to be frustrating for one thing, but not just for the treatment professionals in this case. Of you'd love to be able to help him, and that's frustrating. But then it's got to be for him. That's intimidating. And in that case, if I'm in his shoes, I'm needing to do something that is probably very difficult at his stage, which is to do a lot of self-management before getting into the heavier treatment.
Correct. So right now he needs to titrate down, and this can take him years to do with, again, with having somebody managing his vitals throughout. And another side effect of Suboxone that a lot of patients complain about is depression. So he's feeling extremely depressed and hopeless. And again, this was a patient that if he called us and he was taking 4 Percocets, in a few days in the hospital, we could get him through that withdrawal safely. Wow. So that is prescribed by a physician that doesn't have enough knowledge to be prescribing this drug. And that is a physician that has gone through the training to prescribe this drug. Now, imagine numerous, several healthcare workers without any training. So that's a concern.
So that brings us to a question I have, which, we talk about the things that maybe should be focused on, right? And I'm interested to see what you guys think. If there was a slice of resources that we could take and throw at mental health or training or different things like that, where would you allocate it?
I think education, mental health. I mean, we're always chasing the issue once the issue has become a crisis. allocating our resources to prevention allows us to treat the people that are already suffering without having the income of new ones, at a level that we can never handle.
So you say proactively, like more for, well, proactive. I mean, we don't really funnel people into mental health treatment until there's a crisis, as you put it. It's all one of the biggest critiques of mental health treatment is that it is pathology based, right? And you see a movement to be more proactive in the sense of saying psychological health is just health, right? And that line of thinking is new and is different in a way from saying, well, when you have an event, come to the hospital and we'll try to stabilize you so that you'll be literally safe to your physical safety when we let you out in a few days. Instead of saying like, boy, everybody should be getting education and being screened for it, just along with cholesterol or, blood pressure, or any of those measures that we would usually take.
Correct.
I think it's very unusual that people get any sort of real treatment. In fact, I would say that the reason Suboxone's kind of being used as kind of because nobody is really getting any significant treatment. So to get a significant treatment, you have to be established with somebody who you're connected with, who you feel like you have confidence in, is helping you understand what's going on. And there's a established relationship that lasts over time where there is a desire to, rework and deal with some of the things that are limiting you in your life or causing you to cope through an opioid or other things like that, and helping give you time to, for the brain. So there's, our emotional life and our personality and, and what's going on situationally in our life. And then there's how the brain is sort of coping with coming off of an opioid and all those things. So there's a number of factors and rarely do people get established in a process and with a, therapist or that is going to really work with them to kind of work things out over time. And so it's unusual that you'll see that. I think it's kind of what you're speaking to, Claire, and certainly Dwight, what you do. So I think people do best potentially when that's happening, and it's not like there's a fix-all to anything. But I think it gives people the best chance to really get to know themselves, understand themselves, and then have more options to creatively sort of, deal with their lives. And, so there's a million reasons that's not happening. Some of it's financial. Some of it is like you were saying, although it's really not true anymore, that, it's pathology based. It's really not pathology based. That the idea of psychotherapy, it's really more of, based on humanity. It's just everybody's going through different things. It's hard to be alive. It's hard to make your way in the world. It's hard to juggle work and relationships and family. All these things are hard. So I think what happens when you get into good treatment is it feels like you have an ally to sort of work those things out.
It is, something. I hear what you're saying. I think that sometimes people go through that crisis in order to access, but you're right. Once they get into therapy, I think the approach has become way more focused on the person. I will say too, I do see some positive leanings in an individual and group thinking with people. I remember going to a career day a couple of years ago at my kids' school, two of my two older kids, and when I gave a little presentation about, what do you do for a living? Oh, I'm a therapist. And in all the groups that came through, these little groups of kids, somebody in the group said, I have a therapist. I have ADHD. One kid's like, well, I have autism. Here's what that means. And they weren't ashamed of it. And so I think one of the benefits we see with the up and coming generation is that there is a little bit more of that. And some of that goes to good decisions by parents to proactively reach for that. But so I think you're right. There is some reasons to be hopeful, but Are we seeing that on a grand scale to allocate resources to make sure that that's happening to educate the public? And I think that's exactly, those are great things to be saying on our wish list of what would happen.
That's right. That's right. It's also hard, right? What is that? The Greek word argo means to be in the arena, and it also means agony. So to go into therapy is a type of agony because you're in the arena. You're in this area where you're to get there. You become more self-conscious. You're talking about yourself, and there's somebody who's witnessing, and there's a impediment to sort of do that, which is why often symptoms sort of dictate people getting into therapy, because the symptoms get bad enough that the agony's there and then they want help. But the truth of it is, once you're in it, and if it's going well and you start to titrate and understand, it ends up just the opposite, right? Where it actually becomes a place of relief, and you begin to feel, what healthy dependency can be. And since and I would say that dealing with health and understanding healthy dependency may be one of the most confused things culturally that we have.
I would just like to finish saying that there is no right and wrong when we are treating people with responsibility and respect. But we need to stop focusing on effects of the condition and start looking at the patient in front of us. They're often unseen because we concentrate so much on the side effects, the elements that we can see. We become blind to what is not in front of us. People want to be heard. Sometimes if they can't afford to go to psychotherapy every week, at least the person that is treating them, before you decide what treatment you will give them, hear them out. Find out where they are, where they want to be, where they should be. Allow them to speak to you. Allow them to feel like a human being. And then go from there. Make your best evaluation, the best possible treatment option without, preset protocols. That is so important.
Thank you, everyone, for joining us today for our discussion. As always, we love fielding your questions about opioid dependence, about recovery, mental health, addiction. This is a program that is really out here to help people to make good decisions and to feel some hope around these very, very challenging issues. Speaking of that, if you have questions that you would like to share with us, please reach out to us. Send us an email at info@opiates.com or hit us up on Twitter @opiates. Anything that you'd like to share with us is something that we can definitely use in the creation of the program, and we also just love to connect with people who are listening. This podcast is, of course, a production of the Waismann Method Advanced Treatment for Opioid Dependence and produced by Popped Collar Productions. As always, our music is the song Medical by Clean Mind Sounds. The show is hosted by Claire Waismann, who's a registered addiction specialist, substance use disorder certified counselor, and also the founder of Waismann Method and the Domus Retreat, and by David Livingston, licensed marriage and family therapist and clinical director at Domus Retreat. We just want to remind all of you listening again to keep asking questions, because when you ask questions, you're on the track to find answers. And if we can find answers, then we can find hope.